our second day of this is our second day of session first session of phase 2, that is economic evaluation of public health programs, and facilitated by our very own uh, Professor Dr. Borun Kanjilal sir. And today we are happy to have Dr. Sanjeev Bandyopadhyay. He is the State Secretary of Indian Public Health Association, State of West Bengal. So before going to the discussion, I request our beloved State Secretary, Dr. Sanjeev Bandyopadhyay, to address the audience.
Thank you, Anirban. Actually, I was even yesterday in this program for a very short period of time, but I was there. Anyway, good evening, everybody. So, as Anirban already told, today is the second day of our advanced course, or according to sir, this is very basic of the advanced course. Actually, getting Professor Dr. Borun Kanjilal as a facilitator is a very fortunate thing for us. And I'm sure that you all enjoyed our basic course, and also you will enjoy all the remaining courses also. Anyway, as a state secretary, what I want to say that we will continue this type of CMEs or workshops or something like that in future time also. And now we are planning to start some offline CMEs also, though it is in very nascent stage, but we're planning to start these types of programs. And I'm thankful to Anirban because actually I just can't resist myself to announce that though it is in very nascent stage, we are planning to have our state conference, and if possible, one Eastern Zonal Conference here in our city, Kolkata, in January. So hope you will all help us. And Professor Borun Kanjilal sir, what I want to say that before, I always hope that you always stand with us and help us in the way in which you have helped us in past also. So thank you all, and over to sir. Thank you.
Thank you, Dr. Sanjeev, and all the participants. So what we'll do today is that we will have a recap session where we take up questions or comments, and then we'll have what we call sensitivity analysis. And then finally, we'll have some applications. Actually, I'll share two applications specifically of this, what we have learned so far. And then one application come exercise that you can do yourself. So this will be my second presentation. So today's teaching a little bit kind of technical, but the main purpose is that we don't expect that immediately you will be able to execute these things, you'll be able to perform these functions. But what I can definitely say that, if you really follow, then you will be able to understand the modern literature on this issue, especially the public health. Any journal you open nowadays, you will get this type of literature. And so to read that and to understand that, I'll try to give you a kind of a roadmap and the concepts you require to understand that. That's what I'll try to give. But this should be supplemented by reading and also doing it by yourself. So just, attending a 1 hour or 2 hour lecture is not enough. I know that you understand that very well. So first, a recap session. Any question, any comment, anything that you want to share?
Sir, what are the recursive events in decision analysis? I couldn't understand
Who is
that
asking that? Shantanu Ghosh.
I'm Shantanu, sir.
Yes, recursive means recurring, actually. The things that recur, like chronic disease, the problem doesn't end. It goes on and on and on. So these are called recursive events. So on the other hand, there are acute problems, which either, you die or you get rid of that problem, that kind of thing, actually.
Okay.
That is non-recursive. But chronic diseases are more recursive events.
And another question, in the example of the cost-benefit analysis on the family planning program. Hello.
Yes, go ahead. It's echoing, actually. I don't know what's happening. Yes, go ahead.
In a cost-benefit analysis. Hello.
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 Yes, Shantanu, we can hear you. Please proceed.
Okay. So in that example of cost-benefit analysis, there was also a cost per CYP, and
Yes.
there was also my question is that when we perform a cost-benefit analysis, will we have to perform also the cost-effectiveness analysis and cost utility analysis? The cost-benefit analysis part is the investment of 1 rupees gives us a return of 3 rupees, like that. So these examples contains all. So will you have to do all these things while we will do the cost-benefit analysis?
Yeah. No, usually we don't do that. When we say cost benefit, because they are basically giving you the same information, and cost benefit monetizes the effect outcome, whereas in cost effectiveness keep the outcomes as it is, like health outcome. So basically they are same, but they are so presenting in a different way. Usually you present one.
Okay.
And what is your question about CYP? You have any question on CYP?
And that was the part of cost effectiveness analysis.
No, really. CYP is not the outcome. CYP is a kind of process variable. CYP means couple of years protected. That is when you have contraceptives, basically you are protecting yourself. And when the couple is taking contraceptive, the couple is protecting themselves. But the question is that just taking one spacing contraceptive once will not protect you for life. It will probably protect you for the day, but not for the whole year. So you have to take a series of contraceptive specialist spacing to protect you for the whole year. Once you protect the whole year, then we say that, like DALI or like Quali, we say that we have generated one couple year protected, one CYP.
Okay.
So, for example, in sterilization, usually it is about 13 to 14 CYPs created by one sterilization, because it's not only that year, but also the subsequent years also you are protected through sterilization.
Okay. So it's a part of the utility or
No,
effectiveness.
CYP is not utility. Utility value is in that study. Utility value was DALI. DALI awarded. Utility is the DALI. So you have to convert CYP to DALI. That part I have not shown you. How do you convert that? But we have to convert that CYP into DALI. CYP is just a kind of intermediary variable. It's not an outcome variable in the sense.
Okay.
Dr. Subarna Sinha Mahapatra, please unmute
Yes, sir.
yourself.
Yes, sir. I have one question. Under willingness to pay approach, there is one terminology, conjoint analysis. Sir, kindly please once again explain it.
Yeah, conjoint analysis is basically, it is used by mainly the environmental economists, the environmental people. It gives you different situation, different status. And then they say that basically that how much you want, and first rank those status, that which status you like. How do you feel if we have Sundarban mangrove forest as it is now? So you give you a feeling, and then also you ask, how do you feel that if we the rivers are not polluted in Sundarban? So that's another status, another feeling. So different attributes of the same thing you present, and then on the basis of that, the people rank, and then accordingly valuation is done according to the ranking. This is usually conjoint analysis. But in health, actually, we don't see that much conjoint analysis because ranking is very difficult in healthcare. So that's why it is not done that much.
Sir.
Any more questions? I think, sir, you can now start today's session.
Okay, so you can ask question anytime, raise your hand, and you can ask any question. And if there is any problem in the visual, the screen, if you don't see the screen, please immediately let me know about that. What we'll do first is what we call sensitivity analysis. Now, to go back, what we have done so far is basically we have seen that how to do an incremental cost effectiveness analysis. How do you do that? You first get the cost. If there are two interventions or two options, two alternatives, then between these two alternatives, you compare their costs. One alternative is, suppose, base alternative. That is, you are comparing with respect to base. So in the base, there is a cost, and now you add something for an intervention, that will be your incremental cost. Similarly, in the base, you get some results. You are still getting some results, and you are doing intervention. As a result of intervention, you are getting some extra result. So this is the incremental effect. And when you divide this incremental cost by incremental effect, that becomes your main point. And then you see that what is the cost per day. One particular problem in this case is that the numbers we are getting are called point estimates. That is, we are getting single number actually. When we say cost, how much is the cost? We are getting one number. Or what is the effect? How many DALIs were aborted? Then we get one number. The question is that how reliable is that number? As a researcher, you would always like to know, or even policymakers, the first thing they will ask you that you have done this study, you have come with a number, and you are saying that it will take about 300 rupees to generate one QALY for this disease, and you are telling me to invest on that. How am I sure that you are coming up with the right thing? Your results are correct. You have taken so many assumptions. So what will happen if one assumption fails? And then in that case, you have to answer that. The way the researchers respond to this question is what they do sensitivity analysis. And so every paper you will see, there are thousands and thousands of papers now on this, and everywhere you see, after the main thing that we have done, there is one section called sensitivity analysis. So we need to understand very basics of this analysis. You don't have to get all the details of the analysis. Some of them are really highly rigorous, and I will not get into that much rigor. I will just give you the concept part so that when you read a paper by a public health researcher, you should be able to understand what is going on here. What we'll do is that with the calculation we did, if you remember, that breast cancer screening, there are many critical components there. For example, we talk about sensitivity, we talk about, specificity, we talk about prevalence. These are very critical components. Unless you take that some number, you will not be able to calculate all these effects, etc. So what happens that when you take those, say, for example, prevalence, we take 0.004. Now, where did you find the number? Somebody may challenge you. So then your answer will be, "Theek hai, you don't believe me. So let me change it then. Let me increase it and let me decrease it and then see what happens to the result." So from 0.004, you make it 0.006 and then do the whole thing again. And or you reduce it to 0.002 and do it again. If the results are too sensitive as a result of these two changes, the result comes completely different. Which was cost effective is not now cost effective, then is very much sensitive, your assumptions. You have to be very careful. You'll be very happy if even if you change the parameters, increase or decrease, the main result doesn't change much. The numbers will change a little, but not much, so that your main conclusion remains the same. This means that it is a very robust methodology you have followed. And as a researcher, you should feel happy then. And you should be able to be confidently respond to the health secretary who is asking you this question, that what is the meaning of these numbers? Oh no, how can I believe you? Why did you assume those things? So you say that I have now changed the assumption. See, we are getting same results. So to judge the robustness of conclusions, you need to do that. And also whether it is sensitive, results are very sensitive or insensitive to changes in parameter. So there are two major types of sensitivity analysis in the papers by public health researcher. You'll see one is deterministic, another is probabilistic. Deterministic, again, are two types, one way and multi-way. So many papers do just one way and leave it, but nowadays, if you look at the papers, you will see that they are doing, even some papers do all three, one way, multi-way, and then probabilistic. Probabilistic gives you much better information, more important evidence. So people nowadays, they are doing that. Unfortunately, the softwares that we use nowadays, for example, Triage, it calculates all the probabilistic sensitivity. It does the sensitivity analysis. You don't have to do much. Before that, let's have a clarify a concept first. Now, we talked about these thresholds. But what exactly does it mean, and then what kind of thresholds we are talking about? Now, in incremental cost income ratio, for example, in the last exercise, breast cancer screening, we have got $305 per QALY was the answer. But how do I know that this is a good number or this is a bad number? Should I be happy that it is 350, not 750? Or should I be very sad because, it is 350 is too high? How do I know unless I compare with something? In that particular case, we compared it with base, but actually, when you compare with base, it's not really comparison. You just talked about what is the incremental gain you have achieved this intervention. For a real comparison, you should have base and you should have at least two interventions so that you can compare these two interventions. That we didn't do. We have only one intervention. So in that case, what we do usually, we use a threshold. That okay, if your number is less than this, then that's okay. And if your number is more than this, your number is $350 per QALY, and my threshold is, my benchmark is $500 per QALY. Then you know that this is the benchmark. This is the golden line. So if I have less than that, then I should be happy. It is cost effective. So these thresholds are extensively used by the researchers. There are many types of thresholds. The major three types are: one is externally determined. This is the so-called WH recommended threshold, which have been criticized, appreciated, used many times by many people, which is so simple that you immediately get tempted. That really, I didn't think about it. You see, this is so easy. The threshold is that any intervention, whatever you do, is cost effective if your cost per QALY is less than or equal to 3 times per capita GDP. Now, for example, in India, you are doing an intervention in all over India, and you want to know whether it is cost effective, and you don't have any comparator, nothing to compare with. So what you do, you get your number, and then you calculate, you know the per capita GDP of India, multiply it by 3, and then if your number is less than that, then you say that it is cost effective. It will be very cost effective if it is less than equal to per capita GDP. So if India's per capita GDP is $1,500, for example, then in that case, if your cost per QALY is less than 1,500 for an intervention, you can say that now, according to WHO standard, I am in a good position. It's a cost-effective intervention. Now, this is very simple, but at the same time, that's the reason probably it has been extensively criticized. And for example, where from you got this 3 times thing? Who decided it 3 times or 2 times or 4 times? And what is the basis of all these things? So it is almost like World Bank's poverty line, $2 per day. And also it from country to country, there is variation. So how does it capture the variation? So forth and so on. But if you don't have anything, this is one. Second one, which is extensively used and now being used in every paper, is what we call the willingness to pay, but this time not by the people, but by the government. So whenever a new intervention of government or what we call the provider, when a new intervention comes, and you go to government, government probably doesn't understand DALI or QALY or anything. The government will say that, okay, for this my budget is this much. My budget is 30 million rupees for this intervention I can spend. Now you know that your intervention will, produce how many QALYs it will produce or how many DALI it will avert. You know that. So in that case, you divide that budget into your QALY and you get cost per DALI. So you say that government is willing to pay then 400 rupees per QALY or per DALI, etc. This will be my threshold. So whatever intervention I do, my cost per QALY should not be more than that. This is the typical W2P thing used in public health research. And third one is also easy. It's called league table. And there are 2 types of league table. One is a general, universal. Another is country-specific league table. These league tables, what they do, the researchers already did a lot of studies and they get this number, cost per DALI for different interventions, and then come up with a matrix, come up with a table, and then they give this table is available public domain, so you can use. For example, I will show you how does it look like. For example, in UK, this is the one example of league table. This is very big, but I have just given a certain portion of that. For example, one intervention is the GP anti-smoking campaign, and the intervention is that the GP will advise to give up smoking. Now, naturally, some people will give up, but there is a cost for that also. So cost per DALI gained in this case, QALY gain will be 500 pounds. Pacemaker implant 1,500. By this way, different intervention you get cost per QALY. So heart transplantation, for example, to generate one QALY, one quality adjusted life year, you have to spend 10,000. So the question is that Since in UK, everything is the government, national health system. So the government has to decide whenever somebody comes with some intervention, the government has to decide whether they will spend money on that. And so they, government ministers, they don't understand. So there are organizations like NICE, they have researchers and they calculate that what is the cost per quality. And they also decide a threshold that government should not go above that. In NICE case, now I think threshold is 30,000 pounds per quality. But suppose it's 25,000 per quality, then government will accept probably up to hospital hemodialysis, but it will not willing to fund surgery for intracranial tumors, which is usually very expensive kind of thing. So government will say, I understand it's an important thing, but sorry, just to produce 1 year, one quality adjusted year, I cannot spend that much. So this is a huge money I have to spend. So I have to stop at 25,000. So this is called threshold. So this is league table used as a threshold. So these are the three major things. And if you look at the papers, it comes again and again, this threshold concept. Any question, anything that you want to ask? Okay. So there are two types of sensitivity analysis. One is deterministic, another is probabilistic. So the idea is basically, again, is that when you do this type of analysis, you do through lots of parameters. And so these parameters, if they are assumed to be non-random, that is not uncertain, they are kind of certain, whatever the value you are getting is fine. So then it is called deterministic. So there are two types, as you say, one-way and multi-way. One-way or univariate sensitivity analysis is basically if there are 5 parameters in your analysis. For example, in our case, it was sensitivity 1 parameter, specificity 2nd parameter, prevalence 3rd parameter, and then cost, unit cost was a parameter. So one in the univariate case, you cannot change all of them. You change one. You can do one by one, but at one point of time, you can change only one parameter. So when you change the sensitivity from 0.89 to 0.79, then you may say that, okay, let me see what happens to my result now. So this is one way sensitivity analysis. And as we say that if a small change in your input parameter causes a huge change, large change to incremental cost income ratio, then it will be very sensitive. But if a large change in input came, 30%, 20%, 30% change in the input doesn't change that much, the output, then it will call that as robust. In the second case, you should be very happy. In the first case, you should be very careful because reliability of the result will be at stake. So this is one example. For example, the one cost effectiveness ratio was done on the HIV intervention. So for that one parameter, one assumption was that you assume best case estimate, which is 20%. And based on that, and you have the cost data, and then you calculated that $39 required to generate one query. So now you are doing sensitivity analysis. So you are creating two values. One is low value, another is high value. So and in each case, you calculate again. And you see that, when you change the value low 5% less, then you huge change, 36% changed. From 39, it changed to 53. So it is a little bit sensitive analysis, we will say that. In our case, if you remember that we have taken also base value and then low and high. So one way to do this breast cancer screening program, do sensitivity analysis, take that low value of sensitivity and high value of sensitivity, and then see that how much difference does it make. So there is a new concept come here this is used by the papers. It's called tornado diagram. Since the diagram looks like a tornado, like a funnel actually, and then that's why it is called tornado diagram. This is in one way. What do they do? That instead of presenting the result, sensitivity results for one parameter, we have shown the table just now, right? This is for one parameter, which is HIV seroprevalence among pregnant women. There may be 3-4 other parameters which need to be changed one by one, but difficult to show in a single table and then interpret that. So what you do in this case, you want some picture where all the parameters you changed one by one and what is the result there. So what happens, what you will do then in that case, so each parameter in the model you change by certain percentage, say 20% plus and 20% minus from their base value. So you have a base value and then increase it 20% and decrease by 20%. And do it for every parameter one by one. You cannot do it all of them at the same time, but one by one. And then you calculate the cost effectiveness ratio and then put this value in a diagram. It will look like a tornado and it will look like a tornado diagram. Here it is not really looking like a tornado. For a tornado, the big deviation should come first and the small deviation should come later. But there are many diagrams that will look like a funnel. That's why. What is happening here? There are several parameters in a particular study. Incidence of disease, there was an assumption. Probability of treatment success, probability of comparator success. These are all assumptions you have taken. Cost of treatment, assumptions or estimates from literature you have taken. And people are asking you that what is the reliability of this thing. So then you say that, okay, what I'm doing now, each parameter I am increasing 20% and decreasing 20%. And see that what happens to incremental cost effectiveness ratio. And as you see, for example, if you change incidence of disease data by 20% minus 20%, ICER is not changing much. It's not changing 20%. Whereas on the other hand, quality of life for healthy patients, the assumptions you have taken, when you take 20% decrease, there is a huge ICER change. Similarly, for discount rate benefits, there is a significant change. On the other hand, cost of comparator, you change 20%, nothing much change has happened. So when you plot this thing, this gives an idea which factor actually is making it sensitive and which factor is robust, which parameter is very robust and which parameter is not. That's the beauty of this thing. Is it clear? Any question at this point?
Sir, who will determine the range of increase or decrease? The researcher?
Yeah, researcher. It is the researchers and they decide. 20% is a reasonably high number. So, and at the same time, it should not be so high that even robust result will change. No, if you take 50% increase. So usually people take 10 to 20%, but it's usually up to you. Most cases they take 10%, and but you have to do the same change for every parameter. That is the key thing here. Otherwise, this diagram cannot be drawn. Now,
So, sir, in the previous picture, the cost of computer is the most stable, means most robust.
yes,
parameter.
most robust. Not computer, comparator actually. That is
Also, sorry, sir.
the alternative Yeah.
Compare, yes, right.
So on the other hand, you will look at probability of comparator success no, when you decrease 20%, it is not increasing by 20%, but it's affecting, it's reasonably high. So this gives you that what factors are very much contributing to the sensitivity. But if you do one by one and separate table, you will not be able to understand that. That is the reason. Second way is multi-way. Now the problem in one-way sensitivity that parameters are changed at one at a time. When you are changing that parameter, you are assuming that other parameters are constant. But 2-3 parameters may be linked together in some way or other. So if they should be changed simultaneously if they are very much linked with each other, and see that how does it affect. For example, if you are changing X, you are not changing Y, but X and Y basically go together, then in that case, it's a wrong idea to keep Y constant. So what you need to do in this case, you need to change them together, simultaneously. And when you change two things together, you can show it in a two-way diagram or table, etc., like this. This type of table you will see in the papers. What is happening here? The numbers within the cell are cost per quality. Now, two variables are there, two parameters. One is price of intervention, another is the effectiveness of intervention. So what is happening here? For price of intervention in changing, and as a result, effectiveness, and you are taking different effectiveness of intervention, and then we see that how cost per quality is changing. So forget 0, but then take other columns. What does it mean? For example, if you take the 300 column, what it means that this is the cost of intervention. And if you assume that your effectiveness of intervention is 5%, then cost per daily will be 17,203. But if your effectiveness is 40%, it will be 8,228. So it gives different range of the program. Now, a different range of the cost per quality. Now, if you take, say, one number, which is, for example, 8,709. This is one number. Suppose you take 8,000 and pick up the number very close to 8,000. There are not many figures are there here. So if there is a number which comes more often, so what you do in that case, for example, here another example, probably it will be clear. Here, the two parameters we are taking. One is the price of antiretroviral therapy, one input, one parameter, and another parameter is the seroprevalence. So we have taken different ranges of seroprevalence. We have taken price of antiretroviral therapy, different ranges. And then within the cell, the number is cost per quality, $. So different values are coming. For example, price is 0.17 and your seroprevalence is 40%. Then your cost is low. Since seroprevalence is very high, your chance of getting result will be very high. So your cost per daily will be 5. So you will to treat many people, will be able to see many people actually. So only 5. But if your price is too high, like 1.07, and your seroprevalence is also very low, so very few people are actually affected. So your cost per quality will be very high, 172. That's the basic idea here. So you see that there are 60 coming several times here, 60 here, and then again on the fourth column, 60 coming, 60 coming. So we're taking 60. Suppose the government is saying now that 60 is my limit. I cannot pay more than that per quality. So you can draw a curve now like this. On the one axis, you can draw a price of SZA, and then another axis you plot zero prevalence, and then you plot. For example, the first point will be first 60 is coming first column. So first combination is 0.17 versus 10%. Second combination is in fourth column, 60 coming again, 0.62 versus 15%. Third combination will be what, 0.84 versus 20%. So these combinations, if you plot this, you'll see a curve like this. And 60 is the standard. So all along the line, the curve, it is 60 per daily awarded. And government doesn't want to go beyond that. So in that case, you can easily say that anything left to this curve is not cost effective. Anything right to the curve is cost effective. Naturally, if the government wants to pay more, they are so interested that they are paying 80 per Delhi, then the whole curve will shift left. That means there will be more area under cost effectiveness. So it all depends on that. What is the willingness to pay by the agency or by the government? In many cases, willingness to pay not just by government, maybe by the donor agency, or maybe by the provider, private hospitals, for example. So donor agency, in many cases, they are very generous in some interventions, and they're very miser in some other interventions. Wherever they are very generous, that means they are willing to pay more per daily awarded. So in that case, you get a lot of space under the curve. So this is your multivariate, multi-way sensitivity analysis. There is another easy way to do multi-way. This is called scenario analysis. Some papers do that also. For example, for each scenario, analysis of the set of extreme circumstances across parameters. So you come up with two possible scenarios. One is the worst, and it is the best. So in the worst scenario, for example, the parameter values that yield the highest cost effectiveness ratio, and similarly for the best, the lowest cost effectiveness ratio, those are combined, and this curve is drawn. So you will see examples. I'm not giving any example, but the more popular one is this table that I shown you. That is usually you see. Which is coming nowadays very much because the softwares now generating this analysis within seconds. So that's why it become very exciting, very interesting to the people now. What is the probabilistic sensitivity analysis? In this case, actually, the parameters. Here again, you are not changing one or more variables at a time, but you are simultaneously changing all variables. And how you are doing that? You are doing through a simulation. Most popular simulation is Monte Carlo simulation. Most of the cases is done through Monte Carlo simulation. So suppose, for example, we have two ultimate parameters. One parameter is basically effectiveness, another is a cost. So, and these parameters, you assume them as random variable. We call it stochastic variable or random variable. Whenever you assume it is a random variable, that means it has a distribution, it has a mean, it has a standard deviation. So you plug in those mean and standard deviation to the software. Software will accordingly generate different values of that same thing, and this is called simulation. So for the simulation, you have to give some parameter value of a variable. Mean, standard deviation are more popular. You give that, the the computer will generate random numbers, and that will be your simulated value. So these variables, you assume that they have a probability, and since they are uncertain, so they have a probability distribution. Now, different types of distributions are assumed. I'm not getting into that beta distribution, alpha distribution, normal distribution, gamma distribution. So people take that, but nowadays you don't have to assume and do anything. You just give it to the software. Software will do that for you. It will check the distribution and accordingly start generating the assumption. So what will get you, two types of output you usually get. Very valuable output, very interesting output. One is that the incremental cost effect ratio, which you have got one number, or in probably single way or multi-way sensitivity analysis, you will get 2-3 numbers more. But in this case, it will generate thousands of ICER by simulation. There is another method called bootstrapping method, which is a non-parametric. This is not simulation, but this is a non-parametric way. I'm not going into that, but somehow what is happening here, that lots of ICER will be generated. Incremental cost effective ratio. We have got one number, $350 per query. So the software now will generate 340, 370, lots of number it will generate randomly. And then if you plot that, it will be a scattered plot. But remember that software is not generating, very haphazard way. You have given it some feedback, given some input. You have given that the ICER you are generating, simulating, this is the mean and this is the standard deviation. So generate that now. So following that input, they'll generate. The second one is called cost effectiveness acceptability curve, which I will show. First, the scattered plot. They look like this. In the horizontal axis, you said qualis, incremental quali, and in the vertical axis, incremental costs. You draw that, instead of one dot, you will get thousands of dots through simulation. And this will concentrate on that. And if you draw a line, just a line is not, actually there are two lines. If you can see another line, another is the dotted line actually, dash line. And there is one bold line. Anyway, what this line will be, what is the slope of that line?
This is a best fit line.
Best
Fitted.
Best fitted, but what is the slope of the line? What is the, what will you say?
Slope is the constant, no?
Slope is constant, but what is the value of the slope?
Okay.
What is,
Value.
what will you call? I'm not asking for any number. I'm saying that what is the definition of the slope? I mean, what is the variable's name? What will be the variable of the slope?
For 1 unit change in the quali, the amount of cost changed.
You
Slope
know,
is-
slope is vertical by vertical divided by
the
horizontal. Horizontal. Vertical by horizontal. What is vertical? Cost. What is horizontal?
Cost.
Quali. So vertical
Quali.
by horizontal means cost by quali. That means cost per unit of qualis. That's the
Quali,
same. That is called ICER, incremental
ICER.
cost effectiveness ratio. This is the cost effectiveness ratio. This is $350 in our last example we have seen. That what is the cost to generate per quali? So if you draw a line, this will indicate one particular ICER because slope is constant. So it will be one number only. But the dots are showing different numbers, actually, different values. And I have not drawn the line to best fit kind of. This is not a regression line, though. So It is just an arbitrary line drawn. Now, what is happening here? The next will be very interesting. It will be like like a beehive kind of thing. And so you can draw lots of lines. And each line will signify one particular ICER. For example, the RC where my cursor is suppose it is 1666 per quali. You take this one is 5,000 per quali. Further left 20,000 per quali. Down 1,000. So each line giving you different ICER. And but this beehive we have drawn, the dots we have got from the simulation. These are ICER from simulation. Now, so consider the case when cost by quali is 1666. That means this third line from the left, third line. You will see there are some points left of that. There are some points right of that. And it seems almost 50%, 50%. 50% left, 50% right. So what did we say about the left points? Are they cost effective or not effective? This line actually creates a particular border line in a kind of boundary. This is the threshold. Suppose government wants to pay only 1,666 per quali. So this line will be threshold, right? So what can we say about the points to the left of this line and point to the right?
Not cost effective.
Say it again.
Yeah.
Just,
They are less cost effective.
yeah,
Yes.
not cost effective. That is that government will not accept them. The left points.
Yes. Left
On
are
the
not
other,
cost effective.
left are not cost effective, right are cost effective. So almost 50% not cost effective, 50% cost effective. So that's what it is written. Almost 50% of the scatters are on the left and 50% are on the right side of the line, if it is 1666. That means half of the points are cost effectives and half are not if the threshold is 1666. In other words, a decision maker looking at this data at a maximum willingness to pay of 166 per quali, and there will be a 50-50 chance that this new treatment will be cost effective. That means it will be below the ceiling ratio, 50% chance that it will be below the ceiling. This is also called ceiling ratio, ceiling cost effectiveness ratio. Now what you do, rotate the line and find another ceiling, say 5,000. So in case of 5,000, what is happening? Most of the dots are on the right side and least number of dots are on the left side. Anna, is it right? Amrita or Sravani?
Yes, sir. Yes, sir.
So is it 50-50 now?
No.
It will about 70-30.
70-30.
70% right, 30% less. That means that if the ceiling is 5,000, then 70% chance that it will be cost effective, 30% chance that it will be not cost effective. Similarly, if it is 20,000, the government is so generous, government agency is so generous that it is like, pumping money, which means that whatever quality you're generating, money is coming more than that, much more than that. So in that case, most of the points will be on the right side. That means it will be most likely it will be cost effective, acceptably cost effective. So that's what it's saying. If it is 5,000, so the earlier share 50%, 50% will now change to 70-30. By this way, you change the ceiling and you estimate the probabilities of cost effectiveness at different threshold values. And then you plot these points in a two-dimensional figure and join the points, you get what we call cost effectiveness acceptability curve, CEAC, which will look like this. It will look like this. Oh, sorry. So there are two lines. One is parametric, another is bootstrapped. Forget about, because they are showing more or less the same. So what it is showing? Suppose it is the horizontal axis, we are saying value of ceiling ratio, that is 1,666, 5,000, 10,000, that kind of thing. And the left hand side, what is the probability of that? So you see that probability 50%, then corresponding horizontal axis, it is not given, but it will be about 1,666. When it is 5,000, then what is happening? What is the probability? Almost 30%. When it is 10,000, almost 90,000. But then it doesn't change that much, because almost it reached 100%. So it will converge towards 1. So it will look like that. And this curve gives you a beautiful picture that whatever the selling ratio, accordingly, what is the probability of cost effectiveness there? How much cost effective will the program is? It depends on, of course, that what is the selling ratio in that. So cost effectiveness or not, it depends on how much money will be available, of course, that. So now if you look at the real interventions around you, and you will say that some of them are really very effective and cost effective. They have established their name. One reason might be that there is high willingness to pay. Government was willing to take high risk. But on the other hand, there are many things where money is not available. So in that case, cost effectiveness is very low. I think these are the things. Now, all of these things require very extensive learning to do it by yourself. But two things that if you just read that and now you read the papers, you will be able to understand the papers. And second thing is that if you can handle the softwares now, if you know that what kind of data I have to give, and you can test that, and you can see that this curve, the computer will generate for you. The software will generate for you. So that is, you don't have to theoretically memorize or anything. So this is all about sensitivity in a very brief fashion I just presented. So any question now at this point? Okay, let us see if some chats are there. First question, Priyasha, and jointly possible give practical utility this types of sensitivity analysis. When are this done? That I will show now. I'll give you few applications, real life applications where the sensitivity were done and how. So it usually comes after the analysis. So after the main analysis, it comes. So wait for a minute. Ceiling ratio is C ratio. Yes, is one of the C ratio. He says C ratio is again $350 per quali is C ratio. So ceiling ratio is the one what the threshold that somebody has decided that we would not go beyond that. We are not willing to pay more than to generate a quali from this disease. That may be a government, that may be a donor agency. So in that case, that becomes ceiling. So whether it will be ceiling or not, that particular C ratio depends on that with who is actually putting it as a threshold. Is it clear, Priyasha?
Yes, sir. Yes.
We'll show some applications, real life applications, and then you will see, and then you should also be able to do this kind of thing. So some applications. Now this is one application. It was done about 4 or 5 years ago in Delhi. In 4 government hospital, there was one randomized control trial was done. The issue is basically that during pregnancy, if you have severe anemia, then what will you do? Now, the standard practice oral iron, but then should we apply IV irons, of course, there. So which one is better in terms of cost effectiveness? RCT could not come up with very standard results. So what they did with the RCTs, at the same time with RCT, they developed a model, decision model, and then did the analysis. So, and then this was published in Health Policy and Planning. Health Policy and Planning, you know, it is one of the Bible of the public health researchers. So it was published there. Shomik Rai and Shilpa Niyogi from IIPH Delhi. So they were leading the team. So from the question, from the title of the paper, it is very clear what is the decision problem here. So the study objective was to conduct a cost effectiveness analysis of IV iron sucrose over oral therapy for treatment of severe anemia in pregnancy. The ultimate objective is to inform policy, so that the policymakers take appropriate step. What is the ultimate outcome of this intervention is to have a safe delivery. And how it is defined by the absence of a composite maternal and fetal or neonatal adverse clinical outcomes. There are some possible adverse outcomes, potential adverse. So if those outcomes are absent, hemorrhage, for example, and there are different types of, if those things are all absent, then we call it a safe delivery. So whether we are having more safe delivery for that. So decision problem is very clear. Should we advise IV iron sucrose for treating pregnant mothers with severe anemia? The comparator or control approach is oral iron supplementation. This is a base, and this is the decision tree. Let me put. By the way, the paper, this paper and some other papers are also given in today's package. So you can see this paper there. So you don't have to bother much. So the intervention is that IV one and control another. In the IV case, chance node is here. You see a circle, chance node. Two things may happen, either hospital delivery. Those people who have taken this intervention, they may deliver at hospital or home. If it is in hospital, then it may be normal baby or then cesarean section. If it is normal, then composite outcome, yes, no composite outcome. If it is cesarean, then also composite outcome, no composite outcome. If it is home delivery, there is no question of cesarean. So in this case, it will be basically home delivery or only composite outcome or not. In control also the same thing, same story. This is the decision tree they have found. Now you need some estimates to populate this model. You have to put numbers, probability numbers there, just like we did in the example. So these are the numbers for IV iron and oral iron. So for example, place of delivery hospital, probability is 0.938. Within bracket, this is the confidence interval. This is the range. So you can, for sensitivity analysis, you can use these two values, high and low. Similarly for oral iron. So all these very parameters are there and their probabilities are there. Then you need cost data. So the cost data and their sources are given. So this is, I'm showing that if you usually have to write a paper, what steps you have to take and how do you do that. Is more or less same for most of the papers. First, you show the probability. You have to take probability numbers from some sources or from your control trial. And cost data also you take from different sources. And then you populate that model and then get the result ultimately. So this is the result. One is IV arm and as the oral iron arm. So in the case of IV, cost is this 7,000 per patient. This is the unit cost. It is slightly more expensive. So the incremental cost will be first minus second, 7,677 minus 6,693, that is 984. Effects. Effects is basically that how many watts, kind of thing. So it is 0.9065 and oral iron 0.87. So here again, this is the incremental additional number of self-deliveries. Actually, you have to multiply it by 100 or 1,000 to get a whole number. So if you take the whole population, how many mothers actually were additional mothers got 32 mothers actually, additional mothers, they provided safe delivery due to this intervention. What is the ICER? 31,951, almost 32,000 per birth. So additional this much rupees you have to spend. It requires additional rupees 32,000 or in dollar term 4,452 per additional safe birth delivery through this intervention. Question is it cost effective or not? So you have to, how do you know that it is a good number? Here oral iron is a base, so you need another comparator intervention to create a real comparison.
Half of intensity.
So you don't have another intervention, so you have to one intervention only. So you use threshold. They didn't use WHO. They took more conservative, very conservative threshold, half of India's GDP. WHO says that if it is equal to or less than GDP, then it will be very cost effective. This study say half of GDP, will be cost effective. So this is very more stringent. Now, why did they take that? That is not very explained. They say that this is since it is much more stringent. So if still we get it cost effective, then it is okay. It is cost effective because you have got $445 per additional, whereas according to their threshold, if your threshold is 797, if the cost per Delhi or per birth is less than 797, then it is cost effective. So in that sense, it is cost effective. Sensitivity analysis. Now the first is the tornado diagram. It looks like a funnel, and then they'll find that most of the inputs are very much robust. Clearly, all of them are robust, not changed much. They changed it by 10%, I believe, and then that didn't change much. Scenario. Then they do the plotting through simulation, and they look like this. incremental cost effectiveness versus control. So on the one hand, they are taking incremental cost as incremental effectiveness, and then they started generating thousands of ICER, and they simulate that thing. And this is what is there. And they have a line there. This is the WTP line, a hypothetical WTP line, I believe. And then finally, they have come up with the cost effectiveness acceptability curve. Blue one is the oral one, and the red one, the triangular, is basically you. So what it says, the probability of cost effectiveness at different willingness to pay there. So they have come up with the thing. So this paper is included in your package. My request will be that you read that and then compare with what you have learned, these concepts, and whether you are able to understand the paper. Once you start understanding, then you will be able to do it by yourself. Second application. Malaria rapid diagnostic test in the elimination setting. So this is the article. This is in China, actually. So as you know that study objective is this. What they took 3 malaria diagnostic strategies. And they considered it from both health sector and patient perspective. They have taken in China 2018. The first strategy is the conventional strategy, microscopy test. So this is called MDT1. So people come with fever, you do a microscopy test, and in the patient with a positive result, this will be diagnosed as malaria. Second one is rapid diagnostic test. They will not use the microscope there. Even if you don't have microscope, no problem. They have a kit, the typical card and all these things, and the reagents given in the kit. And within 15 minutes, you'll get the result. From your blood, you will get the result. This is the RDT, which is much quicker and possible everywhere. You can do that. And last one is that where, and this is typically WHO's recommendation, the first do an RDT, and then if it is positive, then go for microscopic test. And if the result is again positive, then confirm as malaria. So you go through the process. You don't do microscopic test to everybody. You just, those who pass the RDT, they only go to microscopic test. So this is their tree. This is since they have 3 options, MDT1, MDT2, MDT3, and for each there are options are given there. And finally, outcome variables are severe malaria, uncomplicated malaria, and then that kind of thing. And since the diagnosis, the whole problem of true positive, false negative, false positive, that kind of thing will come here again, like our example earlier. So if you'll be able to understand this. So they first give the cost data, and then base value, and then the range for one-way sensitivity analysis. Then they give the probabilities to populate that, and then finally they come up with the result. They took RDT3, that was the conventional going on there at that time, RDT and microscopy. So they compare with that, and compared to that, still MDT1 is cost effective, say. So that is not important. How did they do that? They set sensitivity analysis one way. They did scatter plot. They did. Then there are 2 types of scatter plot. One case Since there are 3 interventions, so they took 1 versus 3 and 2 versus 3. 1 versus 3 are where it is blue, and 2 versus 3, this is the red. So this is similar. So this paper is also included in your package. You can now read and see that whether you are being able to understand. Application 3, which is an exercise also. SNCU, everybody knows about it, I believe, that that one contribution of National Health Mission is that how to treat sick newborns, and we know that in almost all states now, at the district level, there are SNCU, sick newborn care unit, usually located at the district hospitals. This problem came a little bit earlier, I mean, about 10 years ago, when not many SNCUs were there in many states. So the decision problem is that, should we go through, should we construct a SNCU or not? And alternative is that don't do that. Routine management of sick newborns in these hospitals, which is the ongoing process at that time. So there are about 1,000, we are talking a hypothetical district hospital where there are 1,000 sick units who receive care in 1 month through either of these 2 strategies. Sorry, in 1 year. So this is the decision tree. As you see, SNCU and no SNCU, n equal to 1,000. And if you SNCU, there are two possible chance. One is alive at 28 days, another is dead. If you are alive at 28 days, then there is 3 chances that after 28 days, no disability, minor disability, major disability. Similarly, if you are no SNCU, the same 3 outcomes will be there. No, minor, major. So you have to now, you require probabilities and cost and quality information. Those information are given next. First, the probabilities, hypothetical values are given there. And then cost, this is the same values are given there. And there is qualities are there. And in addition to their life expectancy is also given there. So a newborn means that if you save a newborn and that newborn is completely and with no disability survive, then 64 years it will survive, the newborn will survive. That means the quality multiplied by 64, you have to find the total quality gain. So exercise is first populate the decision tree and then estimate ICER of SNCU strategy, just like we did sample. So this is the exercise you have to do, and probably you can show me the results tomorrow. Right, you can start immediately after the class and then continue all day. You have to do manually now because you are not using software. So, but manually, do that. Is this okay?
Yes, sir.
Yes, sir.
Any problem with that?
So we'll see.
You will see. Okay, so you have a lot of tasks cut out. One is doing this. The other one is basically at least read 1 or 2 papers. We have also included several other papers, like, in the tuberculosis, dengue one, malnutrition one. I mean, I could give thousands of papers, but ultimately I thought that, okay, look, 4 or 5 is enough for the timing. If you are really interested, I can give you more, and you can search yourself more. There are journals already there. which basically publish only this type of economic evaluations in healthcare. But all types of journal nowadays publish that. So why not you? Now, any question or anything that you want to ask? But my presentation is over actually. I have nothing to say more for today. But I'll be glad to take up any question. No question? Dr. Shantanu? Okay, yes, right.
So there's a slide, oral iron and the IM iron. And there's a 2 cutoff point of, sir, I could please show this slide. This one.
This is actually, the red one is the more interesting, the IV one, which means that the more you are willing to pay, the
Yes.
higher will be the treatment will be cost effective. So since you are comparing with the basic, with the base, so naturally
Yes.
base will be the mirror image of that, in a sense. So usually, people don't give the base one, there is no meaning of giving because anyway, it will be very bad. But more important will be the red triangle, which gives you a kind of S type of curve. It gradually increases and then reaches a point and then becomes flattens out. That is the acceptability curve.
Okay. So there's no significance of this
There
cutoff.
is no.
Okay, sir. Thank you.
I mean, you can find some significance if you want, but that significance is nothing to say. The significance in this case will be probably at the 30,000 level. It is basically indifferent. You can do either one because their cost effectiveness ratio percentage is same. The probability of being a cost effective will be same if the government pays up to 30,000.
30,000. Yes.
Yes, and I think that's the reason why they have done that. And if it is more 40,000 and 50,000, so basically, in a sense, what it says that around if the government pays more than 30,000, that will be better. But I don't see much, significance of this thing. Usually, they don't see the both of them. Okay. Anybody? So what you do basically now? Start with if you have a laptop, start with an Excel sheet and then do it, sheet and then do the exercise. Probably tonight itself you will be able to finish within 1 hour, 1.5 hours, and then tomorrow I will see that. And tomorrow also I have one topic actually, the Markov models that I will take up.
So which software should we use? Means how to use in software?
Triage. That's the name I have given. There are 3-4 there. The most popular one is Triage. Triage Pro.
Okay.
So
So
they-
in this software, is it means easier than or
you have to be a patient, and then within a few days you will be able to comfortable. They have
Not
the manual and everything is there.
okay.
And also by Excel you can do that. You can have an add-in, and I have given the link also
Yes, yes.
that you
First.
can download that. But I have never done that, and so you can try that also. That is free downloadable. Even Triage Pro, you can get free sample for a few days. But I think that if you are based on an institution, probably that institution should purchase one, software, and then so that we will do this kind of analysis. Okay. All right. Any other question? Tiasha?
Sir,
No.
fine, sir.
Okay. So go ahead with your exercise, and then I have already sent you the presentation. So you just look at and then from you will do that, and let us see what is your answer tomorrow. We'll compare it. Okay. All right. So stop share. And I think Rivu is there, Dr. Rivu. So we are calling it a day today. This is over, I think. I don't know. So anyway, to all of you, good night.
Thank you, sir. Good night.
Thank you.
Thank you, sir.
Thank you.